Okay, good evening, everyone. I am Lauren Gueits, your host of this evening's Airway Health Solutions conversation series with our very special guest, Dr. Reza Movahed, and our topic is MMA surgery case reviews. So welcome, Dr. Movahed. I'm so excited to have you on our platform tonight.
Thank you so much for having me.
You know, I saw your cases over at Dr. Clower's symposium, and I was blown away. I think I must have posted about every case that you did up on Instagram for everyone to see, because there's something really, truly amazing about seeing these cases. We've all heard about MMA surgery. We've heard it's the cure, but seeing is believing. So thank you so much for taking the time tonight. I just wanted to go ahead and give you your formal bio, if you don't mind, unless you wanted to kind of chat yourself. But I
could just absolutely. Please go ahead.
Okay, yeah, because everyone, whoever's not familiar with it, I'd like them to get to know you as well. So Dr. Reza Movahed is an oral and maxillofacial surgeon in private practice serving the greater St. Louis region, San Francisco Bay Area, and patients from across the country. For the past 12 years, his private practice has concentrated in treating patients with obstructive sleep apnea, temporomandibular joint disorders, and combined orthognathic and TMJ surgery cases. After receiving his doctorate in dental medicine from the University of Medicine and Dentistry of New Jersey, he completed prestigious intern and residency programs at Nova Southeastern University and a fellowship specializing in TMJ and corrective jaw surgery to manage dental-facial deformities at Baylor University Medical Center. He then started his private practice, Movahed OMS, in St. Louis, Missouri, with a second office in Walnut Creek, California. Reza is also a clinical assistant professor at the St. Louis University Department of Orthodontics, where he lectures on surgical orthodontics and takes part in multidisciplinary orthodontic surgical cases with residents as an adjunct professor at Nova Southeastern University. He has written multiple chapters for books concentrating in joint and corrective jaw surgery, numerous scientific articles, and is a co-author of a textbook which focuses on sleep apnea and treatment. In his spare time, he is a painter and a musician. So I'm so glad and so thrilled to have you here today. The musician part, I just thought we'd tell everyone what we're doing at the AAPMD. We're both in the group, the Palmonauts. I'm excited to be a new member this year. And Dr. Movahed, why don't you tell us a little bit about what we have in store at the AAPMD?
Oh, it's going to be so much fun. And it's going to be a number of songs that the lyrics are turning into lyrics about Airway, everything from Beatles to Eagles. So it's going to be very exciting putting that to life, in front of everybody. But we got to get practicing those.
Yeah, and I look forward to practicing with you. So I love to see that artistic side. Jen Kirkham is heading that up along with Dr. Barry Raphael. So thanks, guys, for doing that if they're listening. I'm just going to give a quick disclosure, and then we can get right into it. If you want to go ahead and share your screen while I do that, then we can jump right in. So the following presentation is provided for educational and informational purposes only and does not constitute providing medical advice or professional services. The information provided should not be used for diagnosing or treating a health problem or disease, and those seeking personal medical advice should always consult a licensed physician or dentist. Always seek the advice of your doctor or other qualified health provider regarding a medical or dental condition. All right, well, let's rock and roll. I'm so excited for this presentation, and welcome.
And once again, thank you so much for having me. So we're going to do a surgical deep dive, and I'm going to try to fit as much of interesting cases, throughout the night, and answer all the questions that would result as a result of this lecture. Okay, so we went over the offices that I work at. Our office in Walnut Creek. Over the next number of months, it's going to be operational. We were really much looking forward to that. And as mentioned, I teach at St. Louis University. One thing to know about St. Louis University is a birthplace of orthodontics in the country. Dr. Engel very much started everything here, and from there on, other programs started. So I love my job, and as you can see, the painting that you see here is a painting of mine, which is right behind me. Never had a chance to share it as such, but my work and also evaluation of faces is a perfect marriage between art and science. So the general procedures that we get to do in our practice are LaPorte 1 osteotomy, which we'll go over a number of those, sagittal split osteotomy, which would be for advancement of the mandible, and genioplasty or genioglottal advancement, as well as TJR. total joint replacement, which has its place, but we have to know when the place comes into play. So it's when you combine these procedures together, it's a powerful tool. You can do some really beautiful things with these procedures. Take a look at this patient, extensive incisal show. Lips are not coming together. We all know how much lip seal is important, but with corrective jaw surgery, we were able to bring the lips together, get the proportions of face right, allow the patient to breathe through her nose. And in this case, classically, we used to set back the lower jaw, and that would be it. We no longer do that. We actually wind up advancing these jaws. As you can see, better profile, better bite for the patient. But one of the main things that we have to really talk about here is stability. What is a movement too large to do a regular bony surgery? And I'm sure that's the question that we're going to get to. And what do we have to look at before embarking on the voyage of becoming a jaw surgery patient, or what to recommend to your patients? So this gentleman is from Arizona. He came to us with facial asymmetry, and he was very much adamant that he did not want a total joint replacement. This is a group of the movement, 7 millimeter in the upper jaw, 20 millimeter in the pagonion, and virtual planning that was associated with it. Automatically, you can see in these images that the condyles are small, they're hypoplastic, and more resort on one side versus the other. So we did our MRI and everything else. No disc was in place, but the orthodontist was adamant that, and as well as the patient, that no total joint needed to be done. So we did the movements, as you can see before and after of the image, lots of plating. And here's the immediate post-op of the patient, about 2 to 3 months after surgery. But things did not stay as such. We made improvements, okay? But as you can see from the year 2013 to 2016, the joints started breaking down. You can see on the left side of your screen that the condyle, it was already small to begin with, but over a period of 3 years, everything started to break down. So we wound up doing total joint and upper jaw for the patient. And the bite was all over the place for this patient because of that very reason. And nowadays, I will be a lot more adamant about sticking to what's right for the patient and not given to patients' wishes. And this gentleman, Michael, as well, he agreed that probably that would have been, not probably, that would have been the right thing to do, to refuse to do the surgery. So what we wound up doing for this patient, by advancing his lower jaw, we weakened the bones on the side. So a pathological fracture as a result of ground force trauma is possible. We don't want to put our patients in that situation and position. And this is the final image that we have. We're a number of years after, and everything is stable for Michael. And this is a bite that, was still, he's working on some basically correction. So we're waiting to see the final aspect of it.
Dr. Movahed, could you just
Yes.
tell a little bit about the etiology of this condition? There was a question in the chat.
So this most likely was ICR, as I'm about to show you another case that's coming up for us, because he didn't have any autoimmune issues that were affecting him. So idiopathic condylar resorption most likely was the culprit for him, which is often we see in young Caucasian females. Take a look at this case. This young lady with ICR, she had three rounds of orthodontics and also 2 double jaw surgeries. Okay, lips are not together, upper jaw and lower jaw are still back. And after the 3rd time of orthodontics, when her bite opened up, she knew she had to do something different. A 3rd jaw surgery would have been just insanity. So we're getting ready to do her surgery with total joint and upper jaw to revise it. As you can see, the joints are hypoplastic, broken down, and that's the reason why it's so important not to hide this information under the rug and face it head on, because otherwise we're going to wind up in a situation of relapse. And that's not what we want. This is a plan that we have for her: removal of hardware, placing total joints, and doing a nice counterclockwise rotation so that we're going to be able to basically recreate the profile that she's supposed to have and the airway that she's supposed to have. And this is the profile that we're looking to get. Now, let's take a look at another case. This young man came to us for evaluation of his bite, and he was recommended setback of the lower jaw. As you can see, we have transverse discrepancy of the upper jaw. So a lot more needed to be done. Our recommendation was double jaw. It took him a little while to figure out that that was the right thing to do. But I want to show you basically a bit of the studies that we did on a group of Korean patients that had setbacks. So we noticed that obviously, as one would think, that front to back and transverse volume of the airway changed for these patients and decreased. And also, we did the fluid dynamic studies for these patients. So advancement for the patient was performed in the upper jaw and lower jaw instead of setting back the lower jaw. And you can see that airway improved instead of getting smaller. So that's the right thing to do for these patients. And the final bite, we were able to expand it, get a nice wide arch and better smile, nicer smile, better bite, and a bigger airway. As we mentioned, obstructive sleep apnea is one of the main concentrations of our practice. Everything that we do. This is a book that was mentioned, textbook for management of obstructive sleep apnea. Just recently, it was translated to Korean. So we were really happy that there was interest in this book in Korea as well. So as you all know, gold standard for evaluation of obstructive sleep apnea is PSGs. But it doesn't tell us exactly where the site of obstruction would be. So doing DICE for these patients in office now is so easy to do. We have our flexible scope, and we're able to take a look at the airway. As you can see here, you can see the soft palates, lateral walls, and posterior wall. And we can kind of gauge what it would be that the airway could turn into by advancements. If you give that a moment, you can see that the airway can open up nicely after us thrusting the lower jaw forward. And that's the airway that we look for. We look for the propensity of opening here. And we all use CBCTs in our practices. A cross-sectional area is a big one that we look at, and the morphometry of the airway. It tells us about the joints, what's going on in the nose in terms of septal deviation, and so many more important factors that we calculate into our planning. As you all know, minimal cross-sectional area is important, but it's not everything. It just really adds a good layer to our final understanding of it. Fluid dynamics are also very important for us. It's a very useful tool in understanding pathophysiology of the airway, so we can change a turbulent flow to a laminar flow. And in order to evaluate the difference between those changes, we can turn the airway live from a CT scan and see what the Reynolds number would be. And in these three cases, as you can see, the 3 lines below are post-op surgical cases. And we published that also in AJO. And in one of the cases you can see here, after MMA, the airway opens up very nicely. And the magnitude of displacement was measured, which the area beneath the soft palate for this patient was a problematic area for us. And after surgery, we were able to have an airway that barely moves. And velocity also for us changes. There's an increase in velocity pre-surgery, as you can see, goes to 8 meters per second, and post-surgery, that changes to a much more of a constant movement of airway. There are a number of procedures that we have for treating sleep apnea, and the only one that really applies to all layers is MMA. We used to do phase 1 and then go to MMA. Nowadays, we know that the success rate for MMA is high, so at times it winds up to be our first go-to instead of putting the patient through a number of procedures. So let's take a look at this case. This is a patient who had MMA, 34-year-old male, apnea of apnea index of 28, orthognathy of maxillomandibular, not complying with a CPAP. So Spencer here, as you can see here, his lips are apart, upper jaw and lower jaw are back, and occlusal plane is definitely not flat or not 8 degrees is what we look for. After surgery, we flattened the occlusal plane. This is actually an older case. In addition to plates, I use screws here as well. But more importantly, besides the fact that minimal cross-sectional area went from 31 to 204, we were also able to bring his lips together and maintain a very nice bite for him. This is Spencer post-surgery. Lips are together, better profile, and better airway. And he had to relearn how to breathe through his nose because he was a full-on mouth breather. Now let's take a look at a patient with scleroderma. Okay, these group of patients don't have the longest life expectancy. Not their previous case, but the changes were immense for the patient. This patient's joints were reconstructed with rib graft, and which is a very painful procedure. The skin tells you that she's suffering from this disease. And she was given literally about 6 years to live. And she walked into my office with a nasal cannula. You can see the wires that hold the costochondral graft together. This is what a costochondral graft looks like. Very, very painful procedure, not only in the rib area, but also the healing process of it. And the joint, as you can see, there was gravel. She was barely opening more than 5 millimeters. So main thing that she initially wanted was to just take care of the joint. But I noticed that we're dealing with a small airway and we wanted to expand it. And her pulmonologist and primary physician were very much against her doing the extra procedure. But I knew that was what was going to make the difference for her. Now, this is a final image. A patient that was given only a few years to live and was walking around on a bit of nasal cannula is able to walk around without a nasal cannula, and her medication intake has been reduced by 40%. And she's got a new lease on life, and she can't stop talking about how much this procedure changed her life. Let's talk about cases that are also a bit more complicated here. If you look at this case here, jaw surgery patient. Oh, so was that a question?
That was me. No, I had it on. It came on Facebook. Real quick.
Sure, no worries.
It was you.
Worries.
It was your echo.
Oh, fantastic. Okay, so Michael came to us with sleep apnea index of 30 and constricted maxillomandibular as far as arch is concerned. Orthodontist did not want to do a segmental, was not a fan of it. Low rest oral posture. We made some generous movements here, 7 millimeter in upper jaw, 19 in the pagonion with counterclockwise rotation. And this is the image of the first surgery. His airway improved immensely, and he was able to bring his lips together. This is him 3 weeks after surgery. This is initial PSG with number 30 for apnea index, and we were able to reduce it to 0.3. And he still was having apneic events. So he wanted to advance the upper jaw and lower jaw even further. But I mentioned, if you're going to do another surgery, we got to expand the arches too. So with the distractor, we were able to expand the lower jaw. We expanded the lower jaw by 10 millimeters. And also in the upper jaw with the segmental osteotomy, we expanded the upper jaw and brought everything forward. But what was very interesting for us, that by expanding the mandible alone in transverse fashion, we increased his minimal axial area extensively. And Michael underwent his second MMA after expansion of the lower jaw, and the airway increased unbelievably. You can see how the airway changed from pre-surgery, post-MMA1, post-MMA2, and symphyseal DO. And we ultimately wound up having a much larger minimal cross-sectional area for him. And the last is 427, and we started with 63. And this is 5-year follow-up for him. And what I'm going to do, I'm going to play his dice for you, so you can see without any manipulation of the lower jaw, the airway opened up immensely to the point that it stays open. And that is what we like to see in these cases. Now, let's take a look at another case that had its nuances. This is Bobby. Bobby had a very retinostic maxillomandible. And what we wound up doing for him, because we knew that the lower jaw could not be advanced without us setting back the teeth. This is actually a case with Bill Hang. And Bill recommended doing a subapical for this patient. And it changed the whole trajectory of the case. And we took a step back and 10 steps forward. So every cut that you can think about in the lower jaw and upper jaw was done for this patient. I'll go through that with you. So he had a bit of curve of speed. We took out the first spies in the lower, set back the lower jaw, that anterior segment, and advanced the mandible. And then also did a segmental expansion in the upper jaw to widen it. And on top of it, did the genioglosal advancement. So this was a very tricky procedure, flattening the occlusal level by making those cuts, as you can see, taking the bone basically out and setting everything down, stabilizing everything, and advancing everything at pterygoid plates, 9 millimeter on one side and 11, because there was a bit of a yaw correction that needed to be done. And this is a side view of the lower jaw. His airway increased from 169 to 308. And immediately, his hypertension decreased above and beyond. Again, he didn't have to be on any more medication for his hypertension, and sleep apnea was gone as well, under 5, from 51 to under 5. So, and this is a profile that we were able to get for the patient. So he felt better about himself, breathing better, and also his medical problems we were able to get that under control. Given the time, I'm going to go to a case that includes expansion of the lower jaw as well. Again, here, this is a case that we're presently working on. Patient has a transverse deficiency of the maxillomandible, and since we couldn't really come forward as much as we needed to, like some of our patients, we wound up doing distraction osteogenesis in the lower jaw and distraction in the upper jaw, or expansion in the upper jaw. The upper jaw, we the decision was made to use only tooth-borne device, which was a mistake here, but that's something that we're going to be correcting ultimately. And this is where we started. We were able to expand the lower jaw. The upper teeth wound up getting splayed out. We'll correct that. But what was important is that whenever we expand the lower jaw, there's a concern about the joints. And the joints were not changed at all, because we did a really slow expansion and the joints were able to adapt. And this is when we removed the distractor, you can see the bone in the middle that healed very nicely for us. But the important part is this: we started with 29 millimeter for intermolar distance, wound up at 40.5. That is what every myofunctional therapist would love to have in order to have a better home for the tongue. And ultimately, once the upper jaw is expanded nicely, we're going to have a very nice outcome. And the airway increased from minimal cross-sectional area of 25 to 79. So it is really important for us to pay attention to this dimension as well, because it matters. And I don't think, for the most part, we have really explored it as much as we should. Okay, now let's take a look at a case that involved trauma and obstructive sleep apnea. 38-year-old male with apnea-hypopnea index of 38, and he was bone on bone on one of the joints. So a severe pain, and he initially only came to us for his joint issues, but we realized that he has sleep apnea, and there he goes. It's a combination of joint procedure along with correcting his OSA issues. So this is an image of his joint on the right. As you can see, bone on bone. Left had anterior displacement without reduction for the disc. And we made some big movements for him. 10 millimeters in the upper jaw, 25 in the lower. You can see the counterclockwise rotation and expansion of the upper jaw, as well as genioglosal advancements. This is a before and after lateral set. Airway before, and airway after. So we went from 64 to 215. As a matter of fact, Josh was just recently with us. He can bring his lips together. He's a nose breather. He's doing his myofunctional therapy, and he no longer has sleep apnea. His apnea-hypopnea index was under 5. And you barely can notice where the incisions are with these procedures. So it is a major service to this patient. And he says it's kind of, in a way, it saved his marriage. So definitely take that. And that would be something that I'm very happy about, as you can see here. And he did a testimonial for us that we really hope to have ready over the next number of months. Okay, now let's take a look at another case. ICR, as we spoke about, this is a pathology that we really don't know the etiology of it. Okay, in this case, we have a 32-year-old female. She was very aware of her obstructive sleep apnea, even though it was moderate, because she only was able to get about 3 hours of sleep at night, and resulted in depression. And her face became asymmetric. You can see the can on the left side down. Lips are not together, and you can see we have retrognathia of maxilla and mandible. Occlusal plane is very high, and we have a small cross-sectional area. Bite that we started with, and this is post-surgery. Before and after, we corrected the occlusal plane. This is immediately post-surgery. This case was done with Invisalign, and this is the patient after surgery. You can see the eyes changes in these patients. It's one of the things that we notice. And look at the broad arch and flattened and leveled pitch on roll items that we dealt with. And the profile. This is her 3 years after surgery. And this case was done with Maz Bashiri. We do a lot of Invisalign surgery cases. And more importantly, the patient is able to open up to 42 millimeters. Okay, let's take a look at another case of ICR. This patient wound up having fat graft to the joint. The discs were taken out, and she had fat graft applied into the joints because she was a TMD patient due to the ICR, and she wound up developing OSA as a result of it, because the joints started breaking down and the whole complex started going back. So upper jaw, lower jaw are retrognatic, lips are apart, anterior open bite. She barely can eat anything, so she's malnutritioned. These are the joints that you can see. Not much is left of the joints bilaterally. And this is how she came to us. She had a lot of orthodontics to bring that open bite together, but wound up losing a lot of roots. This case was also done with Invisalign, but we really had very little we could do with the movement of the teeth. So what we wound up getting was much better, because she really wanted to hold on to her teeth as long as possible. Again, counterclockwise rotation, advancement of the maxilla, and genioglossus advancement, 25 millimeter in pagonion and 9 millimeter in the upper jaw. And our goal was to be able to get a nice lip seal and better airway and healthy joints. Again, this was barely any bone for me to even graft after resecting the diseased bone. And this is how the Lafort was done for her in this genioglossus advancement. Before, after surgery, the airway before and after improved. She still could do some myofunctional therapy. She was a bit resistant to that, but we're getting her there. Before and after. That rotation makes all the difference. But this is what we worked so hard for, to get her back to health. The skin color changed, eyes changed, and she used to call herself Dracula, and changed to a normal human being afterwards. And smiles, the patient is able to smile easier post-surgery. It's a 4-year follow-up, and I got to tell you, it took a lot to get her there, because she was very hesitant after numerous surgeries that she had. That's why it's so important to do these surgeries the proper way first time around. And the final bite. Okay, now let's take a look at another case of ICR here. This patient presented to us with TMD issues, and she did not have any issues with her OSA. But she had upper airway resistance syndrome. And as you can see, the midline is a bit off to the right. Here's a bite that we were presented with. We opened spaces for segmenting the upper jaw and expanding it. And this is how it was prepared before surgery, and after surgery. And just to kind of mention to you, she had all the conservative therapies that you can think of, from arthrocentesis to splint therapy to Botox injection. And given her the state and lack of quality of life, she wanted something definitive, and we were able to get that for her. And at this point, she's about 3 years after surgery, better airway, as well as better profile, and also a better bite. No longer the patient has an anterior open bite. As you can see, the lips are together also. We also addressed the lower third of the face that was a bit longer for her, and get the midline also in position. And again, the incisions are very small. You're barely going to be able to see these incisions. Juvenile idiopathic arthritis, and also another cause of condylar resorption. Here is a patient of mine. Is one of my favorite patients. She had apnea index of 21, shortness of breath, joint pain, barely able to open. And we know that a total joint is a safe and efficacious treatment option for these patients. So here's Caitlin. She presented to us in this state, and no joints are present, as you can see. Taking out the wisdom teeth in office under sedation was so tough to do because she barely could open. Not just that, she desatted every single time that we gave her even the most minute amount of medication. So once that was all done, we planned for the surgery, 32 millimeter in pogonion and 7 millimeter in the upper jaw. A very healthy counterclockwise rotation that is about 28 millimeter degrees that wound up getting to 8 degrees. Here's a patient after surgery. The holes that you see in the bottom is us reattaching the masseter. For these big counterclockwise rotation cases, we have to do that. The bite before and the bite after, that's staying stable. The most stable biomechanical movement that we have is a total joint for these cases. Airway improvement from 29 to 204, AHI of 2.5, and this is a patient post-surgery. And 5-year follow-up. And we also had a testimonial by her, which we're very much looking forward to sharing with everybody. 2 more cases, you would say?
Yes, absolutely. Go
Okay.
for it. You're doing great.
All right, we'll do 2 more cases. Let me pick out cases that would matter in terms of what we are looking at. Okay, so let's take a look at a case that involves asymmetry. This patient has chondral hyperplasia type 3. We published a number of papers on classification and also osteochondroma, which is condylar hyperplasia type 2. This is one of the largest ones that I've come across. So you can see how that's evident. You can see the chin is completely deviated towards the left side. And we were dealing with this bite. This is a true definition of malocclusion. And the patient was living like this for a period of 8 years due to the growth that he had in the right condyle, and that's evident to us. This is a cant that we were dealing with, and the space that the osteoma was taking was the whole infratemporal fossa. So with the total joint, initially, one of the recommendations that was made for him also was to set back the lower jaw. We made this case airway focused because we advanced the upper jaw and not, it's just set back the lower jaw in the name of doing one procedure. Here's a bird's eye view, profile view that changed. Airway that we started with minimal cross-sectional area of 94, and we managed to increase it slightly instead of decreasing it, because otherwise would have been definite sleep apnea and earlier death, in my opinion. This is immediately post-surgery. And this is the final of the case. We're still waiting for him to come back and get his implants done. He's living his best life, so it's very hard to get him back in. This is a panel before and after. And this is a final outcome for him. Okay, I'm going to go to given the fact that we're dealing with small amount of time, 2 smaller cases to review. This is a recent case that's not finished. I just did this case about a week and a half ago. Hallermann-Streiff syndrome is for patients that the skull does not grow properly. They have a lot of issues with their eyes and blindness for most of them, and high intracranial pressure and joints that are broken down. And most of them live their life with a trach. This patient did not have a trach, okay? So prior to, and this is the airway we're dealing with. Talk about a small airway. She barely sleeps at night. And she's a 21-year-old young female. You can see the shunt down goes to the skull, and very micrognathia that we were dealing with, smaller arches. So the day of surgery, we wound up traching the patient and advancing the upper jaw and lower jaw. This was all done for the airway. And this is our patient post-surgery. At this point, within a matter of 4 days, she did not require the trach anymore. So we very much are looking forward to her recovery. And her airway, as a matter of fact, we have the image that I don't have here, but her airway improved by about 8 times. So that is something that we're so happy about, and we were looking forward to her sleep study 6 months after surgery. And this is going to be the last case I'm going to present because this is very important. This is a patient that came to us, young female, with lupus and condylar resorption post-MMA. Okay, and she noticed that her bite started to open up after the MMA, even though they did the MMA with really small numbers and no counterclockwise rotation. If you have pathology in the joints, it will remodel and the bite will change. And she was a very good historian of her surgery, and the post at the time afterwards. So here's the bite that opened up right before surgery. But take a look at this. She recorded this very nicely.
I've done it before. Show me your teeth. Show me your teeth.
So we did our surgery in December. This is November 2022. And you saw in a matter of a year and a half how much that bite just started to go back. And this is where we started right prior to surgery and during our in the OR, and we were able to get this outcome. But let's take a look at her after surgery, these are the images. I was presenting in Chicago, so I really wanted to present this case. And you see this incisions are very small. This is a month and a half after her surgery, and within 6 months, you won't even see those incisions. But if you put both of them next to each other, you can see what kind of a change we were able to make for her. Lips are naturally coming together. Profile change. She no longer has the joint pain. And that's as she reported last month to us. Okay, all right. I think I'm going to leave that here since we're basically went over a bit also.
No, I'm glad, because this is so fascinating. I could actually watch this for hours because just the transformations you make are unbelievable. Why don't you stop your share and then we'll open it up to some Q&A here. But I mean, you must go to sleep very well when your head reaches the pillow of the work you do. I mean, just the changes in their lifestyles. I'm sure the testimonials, I mean, you can't even imagine the difference you made in their lives.
I'm very lucky to be doing what I'm doing, but also part of it is that I've gone through this process myself.
Oh, wow.
Yes, I had 2 double jaw surgeries that relapsed. And this is when I was doing the surgery myself. And right now I have prosthetic joint and upper jaw surgery that ultimately got everything where it's supposed to be. But my aim is really to make sure we do as comprehensive as possible evaluation of these patients. So we just give them 1 surgery. Okay.
Wow. Okay.
Our time is limited on this planet. Okay. So I would prefer to spend the time, living my best life rather than spending time in an oral surgeon's office or basically in any doctor's office. So
Who did your surgery?
my mentor, Larry Wolford, did my surgery. Yeah, and that was about 5 years ago.
Oh, beautiful job. No one knew. No one knew. So, what does the recovery look like for these patients?
So for
And
these
yourself?
patients, yeah, recovery is about a month, and I change, as I said, I changed a lot in our practice, in my practice, because of what I went through. And it's a month of recovery. Folks that tell you that they're ready to go the week after, it's wrong. There are some patients that wind up having a really awesome recovery and they feel very energetic within the first week, but the fatigue is there during the first 2 to 3 weeks. So patients, we have 70% of our patients come from out of town. And I have them, if it's a joint and upper jaw surgery, I have them stay for 2 weeks, double jaw surgery, a week and a half. We see them every day. I have a physician assistant that works with me. We change their rubber bands, clean their teeth because they're not able to do it. We suction their nose so they can breathe better. The congestion is the toughest part of it, and really help them throughout their way. But the more compliant that there are, basic things, drinking adequate amount of water, adequate amount of protein for healing, probiotics. If you do these things, you're going to have a much better recovery.
When is it necessary for these patients to have an MRI of the jaws pre-surgery?
Whenever there's any sign of joint pain, condyle resorption, or any of the autoimmune issues, such as psoriatic arthritis, juvenile idiopathic arthritis, let's talk scleroderma, lupus, you name it, or any kind of trauma that they've had, it's prudent for us to do that. If the discs are in place and we have adequate amount of bone stock, we're fine. We can do a double jaw surgery without any concern. And knowing that the patient is going to do well, I follow my patients very closely. We see them every year, and especially my total joint patients. So that's what is important about that, to study our cases and make sure we're doing better and better as time goes on.
Would someone with the type 3 occlusion be less prone to OSA?
You mean class 3 relationship?
Mm-hmm.
That actually, we shouldn't even look at classification when it comes to OSA. That to me has turned to be somewhat of a archaic way of looking at it. But yes, a class 3 patient has more of a hypoplastic maxilla, that means soft palate, has a higher chance of having collapse. But there's a lot of class 3 cases that I'm advancing both upper jaw and lower jaw, and you have a whole lot of patients in class 1 occlusion, thin young males that have sleep apnea and young females that have sleep apnea. So we should just, the classification of the teeth, we should start to kind of put out of our mind and really look at the facts that we have. A drug-induced sleep endoscopy, a polysomnography, and I would say in-lab polysomnography, because there's such variation. One polysomnography is not always going to let you know what is happening. And as I mentioned, PSG tells you what's the extent of your pathology, but the site is diagnosed with DICE.
How would you suggest to make a differential diagnosis to rule out ICR if someone has a reopening bite?
How to rule it out?
Mm-hmm.
So this is the way I would go about that. If it's the disc is displaced, by the way, 30% of populations have displaced disc. Not all of them have ICR. Not all of them are symptomatic. So a displaced disc and a hypoplastic condyle and decreased joint space without any presence of markers for autoimmune issues, that would tell us that likely it would be ICR.
Is ICR a cause for OSAs?
A majority of patients with ICR have OSA. Whenever condylar resorption happens, this is a sequela of events that happen, unless they wound up having premolars extracted, which is a situation is even worse because they bring the bite together by taking out premolars and in upper jaw and lower jaw and closing the bites, which makes our job so much harder to get them back to where they were. But that's a whole talk of its own. But as the condyles resorb, the jaw goes down and back. So occlusal plane steepens. We have a steeper occlusal plane. And the bite opens up. Lips are not together. Now we have a mouth breather. And you know what happens as a result of that. palatal vault gets more constricted, mandible follows it, and there we are. We're in a situation that we have obstructive sleep apnea.
Dr. Bill Harrell is with us tonight. Hi, Dr. Harrell. He says, Reza, great cases. Have you seen a decrease in nasal resistance and tendency for nasal breathing? And do you measure nasal resistance changes?
And I don't actually evaluate it, but almost every one of my cases, if they haven't had any sort of expansion from MRP to MSE or any kind of expansion prior to surgery to match the maxilla to mandible, then over 90-some-odd% of my patients have segmental osteotomies to expand the maxilla. And that also expands the floor of the nose. But we do that up to 10 to 12 millimeters. Any further than that, you have to do other expansions. We have cases that we do MSE before or do MARPI before or SARPI, for that sake. And then when we go to surgery, in order to get further expansion and also align the bite properly, for example, closing that anterior segment, the front fours, to get a nice overbite, because we changed the occlusal plane, we need to do that for most of these cases. So we also do a segmental osteotomy. It's case-by-case basis.
For expansion in adults without surgery where indicated?
Could you repeat that again?
Do you support expansion in adults without surgery when indicated?
So it is a helpful thing. It's a helpful procedure to do as long as you have the mandible to match the maxilla. That's what I would say. The last frontier that we haven't conquered yet is the mandibular distraction, mandibular expansion. And that's not just getting the teeth out of the way. Maybe upright the teeth on the basal bone, but beyond that, it needs to be a bony expansion. Distraction, osteogenesis of the mandible comes with its problems. Chance of loss of teeth, chance of remodeling of condyles. But if you're looking for a better airway, these are the challenges that we have to go through. Because it's not only the floor of the nose and a palate that needs to be expanded for the tongue to go to the roof of the mouth. You also want to make the home of the tongue wider as well. And hopefully, we actually designed our new mandibular distractor, and we're going to be working on a number of cases, series of cases, that once we have the data, we are hoping by next year we're going to be able to present the data.
Hey, back on.
Yeah.
What is the youngest you will do MMA surgery?
So that is for girls, that would be 14, 15, boys, 17, 18. But there are circumstances that could be different. So I've done surgery for boys with severe sleep apnea at age 14. And one of the things that we have to understand is this: when we do a Lefort 1 osteotomy, and we detach the septovamarian junction, and once the septovamarian junction is detached, then the AP growth of the maxilla will stop. And this is slow-growing patients that we're talking about. And if they have a slow-growing mandible, that also, their growth is not going to be extensive there. There's a reason why they have sleep apnea. And if the joint is involved and for them, then there is no way that mandible is going to grow beyond that. The only one thing, as per Barron's studies, we know, and he studied this very well, that even after Lefort, there's a chance 1 to 2 millimeters at age, for example, for boys at age 14, 1 to 2 millimeters, the maxilla can have vertical downwards growth, which is not a bad thing. More incisal show youthfulness. So that would be my answer to that.
If the patient has ICR and is only 14 years old, but has no joint pain, clicking, or popping, is it better to wait to go through the surgery?
So this is a thing. You have to think about surgery as a stress test. Okay, someone who has a blockage in their heart, most of the time they're probably not as active. Okay, you put them on a treadmill. Oh, you could have some major chest pain, right? So the chest pain for doing surgery at any point on an ICR patient is anterior open bite and relapse, as you saw in those patients. So just because you haven't put it into test and the patient is not symptomatic, doesn't mean they have the foundation to build a skyscraper on.
Give us your professional opinion. Why idiopathic condylar resorption? Is it really idiopathic to the point no one knows the possible cause?
So in my practice, majority of my patients with ICR are women. There are very few boys that have it, and it's all Caucasian young women. We don't know what it is, why this is. I gave a grand round at Barnes Jewish Hospital with the pediatric and the routine normal rheumatology departments, and they're so interested because they don't even know. If they don't know, we don't know, and they're planning to get NIH grants to study this. Really, we should be studying the disc. We should be studying the retrodiscal tissue and the receptors on the disc, and what has caused this, and why is it that these discs are slipping and the bones are just not strong enough. So,
The hormonal cause in ICR?
well, those are very much anecdotal studies. That's not full on scientific proof, and any of those studies you look at, it doesn't pass the water test, unfortunately.
In one MMA, you advance the mandible 24 millimeters. What is the average advancement of maxilla and mandible you do usually?
So on average, maxilla can be no less than 7. Advanced maxilla is up to 12 to 13 millimeters if necessary, but for some cases that's really pushing it. But these big numbers that I'm showing you is not just because that I'm coming forward, because if you straight come forward with a maxilla 8 millimeters, lower jaw is going to come forward 8 millimeters as well. It's the counterclockwise rotation that brings the pogonion further forward and really opens the base of the tongue for us. So it is a very useful tool in our back pocket to be able to get a better airway. But the caveat here is that if a maxilla is not grafted afterwards, you're going to have an unstable outcome. And if the patient doesn't wear elastics for 8 to 10 weeks and really monitor, you're going to have relapse with counterclockwise rotation. Dr. Prophet out of UNC, who actually passed away about 2 years ago, as everybody knows. He was very much against doing counterclockwise rotation. They were still doing posterior impactions at UNC. But given the airway situation that we deal with and the benefits of counterclockwise rotation, it is prudent for us to work in a way that we keep that movement stable. And the answer is grafting the counterclockwise rotation to keep it stable.
There's no OSA. How do you improve position of buccally tipped upper incisors if the maxilla is underdeveloped both sagittally and vertically?
Buccally tipped, can you repeat that again?
Yeah, if there is no OSA, how do you improve position of buccally tipped upper incisors if the maxilla is underdeveloped?
Okay, buccally tipped upper incisors. That would be a segmental. That would be a segmental, because with a segmental, the anterior segments, if you can see here, these are where the cuts are made, okay? If there's too far tip, we can rotate it back and this segment would come up, and we're able to, as a matter of fact, this probably would show that very nicely. That anterior segment coming up, one of the things that we shoot for is that the buccal aspect of the maxillary incisors would be parallel to the true vertical line. So we absolutely can have that tool to be able to correct that.
Could TMJ misalignment be a predisposing factor for ICR?
TMJ misalignment, that's very much a loaded statement, but
Okay.
can we be a bit more precise about that?
I'll see if they follow up. Do you think regenerative therapies can be the future instead of these surgeries?
So the last set of, I was at the University of Pittsburgh, I attended a group of not surgeons, but scientists that are working on regenerative therapies, regenerating the disc. But you know what? We're able to kind of regenerate some sort of disc, but the attachment of the disc is the problem. And that's been the problem to understand. We've tried everything. We've tried porcine cartilage, Teflon Proplast that result in horrific outcomes. 80s was riddled. It took completely, the complications associated with that was out of this world. So are we there? Not really. I mean, when I do arthrocentesis, I use IPRF to inject into the joint. Some of the osteophytes flatten, but you're not going to grow bone, and you're not going to grow a stronger condyle. This is just the reality of it. We have to accept it. This is all we have right now. And unfortunately, the research into TMJ, it's not something that's, that extensive amount of that is given funding by NIH. It should be. It really should be, because there's a lot of young women suffering from it.
If a patient is a candidate for MMA surgery and has a narrow maxilla, would the patient benefit from pre-op or prior MSE before MMA, or is MSE accomplished during the MMA surgery?
So, what I'm doing with our cases is that I do a preliminary evaluation for these patients, even before doing any orthodontics. I want to really get an understanding of what is our transverse discrepancy and what extent it is. How lingually tipped are the lower teeth? So we measure for how they could be uprighted on basal bone in the mandible, and we see what the discrepancy is for the maxilla. Up to 10 to 12 millimeters, no problem. I can match that. I can bring everything forward. We just recently did a skeletal and dental study at St. Louis University, cases that were 1 year follow-up. None of our maxillary expansions relapsed. And if anything, some of them were able to be further expanded by the arch wires that were used. So if the expansion is within 10 to 12 millimeters, I do it during surgery. If we need to do more than that, then I would definitely say MSE ahead of time, and then do the MMA along with the segmental osteotomy.
Well, thank you so much. That's all the time we have for questions. And I think if you're up for it, I would love to have you back just for a town hall, just because there's so many questions surrounding MMA surgery. So, as long as everyone's interested, and I know you love to share what you have, what you do and what you're doing, and all the research and the advancements you're making. So I just wanted to go through some of our updates so people know what's going on in the Airway world with Airway Health Solutions. We do have our upcoming mini residencies with Dr. Ben Moralia, our pediatric and our adults. We will send you all follow-up information, so you don't have to write anything down. It'll be in your email. Our advanced mini residency is coming up this week. We do have a couple of spots. If you're still interested, reach out to me or just go to our website to learn more about that. Dr. Moralia will be talking about fixed expansion in teens, as well as the carrier bracket and wire system for expansive orthodontics. We have Dr. Michael Gelb doing his mini residency with us. It's a virtual course on March 31st. So March is a busy month for us. We're excited for him to share his tried and true techniques to get the patient from an acute TMD position ready for expansive orthodontics. And then we also have Dr. Brett Christensen on our faculty. He's an orthodontist of over 30 years. He's been doing this for 30 years, and he's teaching his tips and tricks on how to do pediatric expansion. So it's geared toward orthodontists, but GPs are welcome as well. We have our advanced mini residency with Dr. Kevin Boyd that is coming up in October. It will be live in Florida, and Dr. Moralia will be there as well. We will be hosting it virtually too, so you may want to save the date for that. It's in the Pompano Beach area. We have our mini Mayo course coming up March 24th with Brittany Sierra and Carice Laguerre. This is a course that Dr. Boyd actually suggested. He said we need to have this. So when Dr. Boyd says that, we go to action, and we created a course to help design these preschool children with myofunctional disorders to get them the therapy they need and the screening tools that we need to make sure that they have an early start. We also have our myofunctional courses for the existing myofunctional therapists and an RDH who wants to integrate this into their dental practice. So we have different options depending on where you are. I encourage you to look at our website to learn more or schedule a call with me. We have green dots popping up all over, which is so exciting. So once you take our course, then we get you on our locator. If anyone's looking for an airway dentist, go to our directory here, and you can find someone in your area who is trained and has the expansive philosophy. So please take advantage of that. We also have that internationally. So that's in Canada as well as in Asia. Let me just see something here. We go. So yeah, we are international too, if you're looking for someone across the pond. We do have our Airway aligners that Ohlendorf Appliance Lab. We partnered with them to do Dr. Moralia's expansive technique. So there's algorithms in there that only allow for expansion. So we don't do any lingual root torque. We don't do any intrusion. We don't do any distalization. It's just all expansive. So there's no hidden algorithms that you have to worry about. And you're eligible for that once you become part of our alumni group. And that's through Ohlendorf Appliance Lab. A lot of you guys use the Airway Health Appliances. So Kevin's our partner in that. Here's our public Facebook group. So invite your friends because we will share. Dr. Reza, I hope that you join our Facebook group too, so you can maybe answer some questions. Yeah, terrific. Yeah, so that would be great. So come on and spread the word because the more we know, the more we know. We have Hinman coming up soon. Airway Health Solutions is really proud to sponsor this meeting. Dr. Morali will be presenting Thursday, Friday, and Saturday. His courses on Friday and Saturday are free. So as in free. So that's really a great opportunity to bring your team members on board. It's a great team building opportunity, but to learn more, I know Dr. Ballinger is with us tonight, I believe, and that's where she first saw Dr. Morali at the Hinman, and now she only treats pediatric airway patients. So it's amazing what a spark can do. So if you're interested, come down and join us in Atlanta. And then our friend, Dr. Gerald Simmons and Dr. Kevin Boyd will be presenting here. Dr. Reza, will you be here at this conference this year? In Houston?
I'll definitely try my best to make it.
Yeah, that would be great because I know we'd
April,
love to have
I'll
you.
definitely try my best to make it.
Yeah, so Gerald Simmons heads this up. So we do have a $100 discount code, 2023 SLEEP AHS. So we will give this to you in your follow-up email. So don't worry about copying anything down. In April, we have Dr. G. I'm going to say his name right if it kills me. I always say Dr. JJ, but Dr. Jivanan Jahandran is doing the integration, the key to upper airway health, and all about collaboration. That's coming up April 19th. And we're having an exciting masterclass, and I'm going to plan to have many of these. So Dr. Reza, maybe we can do some oral surgery myths. We really want to break barriers and bust the myths that are indoctrined, and we really want to move this airway health movement forward. So join us May 3rd. It's a 2-hour presentation, Eastern time, 8 to 10. We will offer CE if you need it. Most of people don't need it who are on our calls, but each one is going to bust a couple of myths, and Dr. Carsonson is going to help me moderate that. So that's going to be a really exciting evening. Save the date, and we'll open up registration soon. We have our faculty member, I called her Dr. Carice Laguerre. She's hosting the Dental Culture Con with her co-partner, Chris Williams. And this is a great way to really to bring your team, or if you're in corporate, a great way to celebrate diversity and bring your team to learn all about diversity and inclusion. So check out the Dental Culture Con. That'll be in June in Atlanta, Georgia. And our Airway Palooza. So Dr. Reza just confirmed he'll be one of our speakers. I'm so excited. We'll announce the speaker lineup by the end of the month, but save the date. This is going to be an event like no other. And we're looking to have it 99 points cent. I'll spill the beans here. That's going to be at the Ritz-Carlton. So keep our fingers crossed. I'm trying to lock that down, but it's definitely March 15th and 16th, 2024. We look forward to having everyone there. And then Collaboration Cures, you guys have to come now because you're going to see Dr. Reza and I on stage singing with the Palma Nuts and Jen Kirkham and Dr. Barry Raphael and Dave McCarty and on many others. So this is going to be an amazing meeting. As everyone knows, it's where everyone gathers together. It's for all professionals, so all healthcare professionals, dental and medical. So we're a proud sponsor of that as well. So that is a wrap. I'm going to just stop my share. And what a great evening, Dr. Reza. I thank you so much for everything you do and really for sharing your personal history. I don't think many of us knew that. I didn't know that. We'd love to see your case maybe one day. Maybe we'll show that.
Honestly, I haven't put it yet I haven't yet put in a presentation yet. But
yes, maybe we'll do a Palooza. I'm just always
we'll see.
Well, whatever you want to share, we would love to hear it because your wealth of knowledge and your passion and commitment is really, really admirable. And we just respect you and so glad you're here to help us this evening.
Thank you so much for having me. Really, really appreciate it.
It's my pleasure. And thanks everyone.
It was a lot of good questions.
A lot of good questions. So let's have you back because there was a lot more, but a lot of it was covered in your presentation. But I know I love the curiosity and, I love the work that you do. So, and I love the artwork. So
Oh,
keep
thanks.
on doing what you're doing.
You'll see more when you come over to the studio.
Very good. All right. Well, good night, everyone. Thanks for your commitment and
night.
passion
Thank
to
you.
Airway Health. See you next time.
Bye-bye.
Bye.